don't you see about me? I'll be alone, dancing with no affair. But tell me your troubles and doubts, giving me everything inside now. Well, love straight, so real in the dark. Think of the tender things that we were working on. But slow change can pull us apart. When the light gets into your heart, baby, don't you forget about me.
Absolutely.
Don't you forget about me. Will you stand above me? Look my way, but never.
Let's see. So, come on in, grab a seat. We will keep pushing forward with our dementia series, right? Dementia series. Dementia Day in beautiful McAllen, Texas. Beautiful Edinburg. Okay, so for the next series of talks, you know, there's no better time to talk about drugs and alcohol than after lunch, right? So we're going to start with the drugs. So we're going to start with pharmacology, with medications. And so this is this kind of medication-focused talk is was really stimulated by, you know, these are the questions that that families come to me for. So people will say, you know, my father has dementia, my mom has dementia. Should they see a psychiatrist or should they see a neurologist? Right? I'll get those questions all the time. Who should they see, a psychiatrist or a neurologist? And the truth is you can see either. Either are perfectly fine. I can tell you the patients that tend to come to me though are really the patients where the memory problems and the functional problems are really the least of their problems, right? So what draws families to come see a psychiatrist are when the elder is suffering from psychiatric comorbidities associated with the dementia. So these are things like agitation, aggression, psychosis, mood disturbances, those kinds of things. And so because agitation is such a part of dementia care management, we pulled this pharmacology-based talk, together. So the first thing that needs to be said is that every medication I'm about to mention for use in treatment of elders with agitation is used off-label. There is no medication that is FDA approved for the treatment of dementia-related agitation. Not a single one. No medications FDA approved for dementia-related agitation. So anytime a medicine is being used for that, it's being used in what's called an off-label way. So what that means is that it's up to the experience of the clinician. So clinicians have experiences with different medications, different medication classes, and they say, well, you know what? Your mother doesn't have schizophrenia, but I'm going to try and use an antipsychotic to treat her because although she doesn't have schizophrenia, which antipsychotics are FDA approved for, she has symptoms that kind of remind me of that, so maybe an antipsychotic will help for that. Okay? And that's how these medications are prescribed. They're all off-label. Okay, so we'll talk about the epidemiology and impact of agitation in elders with dementia. And then we're going to really focus on randomized controlled studies. I'm going to show you some of those. And then we'll kind of discuss a review of recommendations for treatment. The other thing to say is that when elders present with agitation, do we begin with pharmacology interventions? No. We always begin with non-pharmacological interventions first, right? And so we want to do a medical workup. You know, if someone is agitated, you can imagine if they're agitated, they're striking out, they're resisting care. You know, if they're doing that because they have a urinary tract infection, well then the last thing I would want to do is prescribe Prozac or that, right? That would be like terrible, right? If pain is the reason for their agitation, then we want to treat the pain and take the pain away. We always try reassurance and redirection first. We try other distraction strategies. There's a whole slew of non-pharmacological treatments that are tried first. Okay? But then once we try all of those, if they're not working, then we might need to go to pharmacology. So what I don't want you to walk away from here thinking is that the first step is to medicate. The first step is never to medicate. Medicating is like the 5th or 6th step. Okay? We never start with medications. All right. So we'll talk about the epidemiology. A bunch of angry people. Okay. Okay. So first we need to kind of describe what do we mean by agitation, and how do you measure that? So one of the tools that's more commonly used is called the Neuropsychiatric Inventory, or the NPI. A lot of the studies I'm going to show you use the NPI to measure agitation. So the Neuropsychiatric Inventory, it's a caregiver questionnaire, and it measures delusions, hallucinations, agitation, depression, anxiety, elation, apathy, and all those other things. So it's a behavior inventory. One behavior it's measuring is agitation. And so the way it does that is there'll be a care provider, a spouse or an adult child, will come to the clinic, and they'll be reporting that they're having a hard time caring for their parent because of agitation. And so to start to get at this, the clinician will say, well, does the patient have periods when they refuse to cooperate or won't let people help them? Are they hard to handle? So this is just a very broad screening question. If the care provider says no, they don't do that, then you just move on to the next domain in the NPI. But if they say yes, then the physician will ask them these other types of questions. And by asking these questions, in a way they're asking for information, but really what they're doing is they're kind of demonstrating all the ways that people can be agitated. So do they get upset for those trying to care for them? Are they stubborn, having to have things their way? Are they uncooperative? Do they curse or shout angrily? Do they slam doors, kick furniture, throw things? Do they attempt to hit or hurt others? And so they'll get the answers to that. And then the question is, well, how often do these happen? Rarely, sometimes, often, or very often. And then it'll be, the severity will be graded. So is it mild, moderate, or severe? Severe means that the agitation is very disruptive and that medications are often required. Moderate, maybe the behaviors are difficult to redirect or control, but can usually be redirected or controlled. And then mild would be the patient responds to reassurance and redirection. So this is an example of how agitation is being measured and what I mean by agitation in elders. So we can talk about the prevalence of it. So the NPI was administered in one study, 408 elders in Cache County. Cache County is in Utah. I'm sure that the population of very northern Utah is very similar to that here in McAllen, right? I'm sure there's no demographic, social differences there. So take that for what it's worth. So this is northern Utah. And they've just kind of followed the NPI at baseline and every 1.5 years after, trying to figure out what is the prevalence of agitation in elders. They have to divide the sample up into those who didn't get any follow-up versus at least one follow-up. And what you can see is that this is about half the subjects, maybe a little bit more than half, have Alzheimer's disease. About 25%, about a quarter of the sample is taking a psychotropic treatment. It's taking a a psychiatry medicine for agitation. So a quarter are taking psychiatry medicines for agitation. You can see only about 5% are taking acetylcholinesterase inhibitors, like donepezil or Aricept or Exelon. And when you look at the prevalence, if you just kind of follow the agitation bar, whether they got no follow-up or at least one follow-up, I mean, you can see about 15%, if you just kind of split the median there, about 15% of elders with dementia in this sample, about 15% had clinically significant agitation. About 15%. So that's pretty common. 15% is common. If you look at, let's see here, follow the bar, right? Apathy. about 20% have apathy. And for delusions and hallucinations, again, you're looking at about 15%. So when you start to think about, what are reasons that people put their loved ones in nursing homes? Why do people put their loved ones? Why do people put their loved ones in nursing homes? No one has ever said, I'm going to have to put my mom in a nursing home because her memory is bad. Right? It's like never been said. The reason why elders go to nursing homes is because it's always related to behaviors or incontinence. Those are the two reasons. It's always related to behaviors or incontinence. The family can't manage the behaviors or they can't manage the incontinence. All right, so then we can start to think about, well, what can we do pharmacologically to treat agitation in elders? And so these are all based on, we're going to talk about different medications, different pharmacology here. These are all based on double-blind, randomized, placebo-controlled studies, which means you're going to have a treatment group, the group that's getting the medication. You're going to have a control group, the group that doesn't get the medication. You're going to give them scales to see if they improve. And neither the patient nor the raters will know if they're on the medication or not. So these are blinded studies. So this is sort of the gold standard way of doing, of determining if a medication has benefit for any given condition. And so we'll start with serotonin medication. So these are SSRIs. Fluoxetine is Prozac, trazodone is trazodone, sertraline is Zoloft, and citalopram is Celexa. So there have been 5 randomized controlled studies of antidepressants. So do antidepressants help with agitation? That's the question. Do antidepressants help with agitation? So out of all of these studies, only one study showed that SSRIs were helpful for agitation. Only one study showed that, that an antidepressant medication was helpful for agitation. And the medication that seemed to be helpful for agitation and struggling and all that was citalopram or Celexa. A challenge here is that this was done on 85 non-depressed elders. They randomized the elder to either citalopram, perfenazine, which is an antipsychotic, or placebo. They only did the study for 17 days. That's it. 17 days. That's it. And what they found is that if you kind of look at the age, this was an inpatient study. The average age of this group, whether they're on citalopram, the antipsychotic, or placebo, was about 80 years old. You can see their mini-mentals. Remember, what's the cut point for a fail on a mini-mental? 24, right? 24 below is a fail. 30 is a perfect score. This is a severely impaired group, right? These are like severe dementia cases. You can see most of them have Alzheimer's disease. The other thing I'll bring your attention to is dropouts. So 52% of the patients who were randomized to citalopram, 52% of the patients randomized to citalopram didn't even last 17 days in the study, right? The dementia was just too severe, the blind had to be broken, and they didn't even last. The problem with all these studies that you'll see, the dropout rates are huge. It is hard keeping elders in these studies. Hard. Dropout rate always hovers around 50%. Nonetheless, for those that stayed in the study, you can see that this is mean improvement from baseline. You can see that the Celexa group, the citalopram group, did better than the antipsychotic group or placebo, right? So here you have the antidepressant group is doing better than those randomized to the antipsychotic or placebo. But then you also see other kind of silly things, like where the antidepressant is better for psychosis than the antipsychotic, right? So like, what's up with that? See that here? The antidepressant is better for psychosis than the antipsychotic, right? You see that the antipsychotic is better for depression than the antidepressant, right? So, and show that over here, right? Here the antipsychotic is better for depression. That's not statistically significant, but nonetheless it's higher, right? So, So in this study, citalopram did seem to outperform the antipsychotic. I think the challenging part here is that the psychosis of schizophrenia is not the same as the psychosis of dementia, and the depression of schizophrenia, or the depression of dementia is not the same as major depressive disorder. These are different processes. So it makes the results so unpredictable. So there's a question? Is there a question? Mm-hmm. 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 Yeah. So the question is that, what we know is that antidepressants typically take 4 to 6 weeks to work, right? That's sort of not 4 to 6 weeks to work necessarily, but 4 to 6 weeks to achieve their maximum benefit at any given dose, 4 to 6 weeks. And the question is what can we really draw this conclusion after only 17 days, right? So what we know is that antidepressants don't reach their maximum benefit for depression until 4 to 6 weeks. But we don't know for agitation. Agitation is not depression. Maybe for agitation they work immediately. Maybe they take 12 weeks. We just don't know. But you're right. That's a good question. Before. Small numbers. That's right. So these are small numbers. Nonetheless, this is the only study. The study I'm showing you right here is the only study that's ever shown a benefit for antidepressants for dementia-related agitation. This is it. And that was done in 2002. 2002. Okay. So some people thought, well, maybe citalopram, okay, that's helpful. Risperidone is an antipsychotic. So now they're going to look at, how does citalopram, the antidepressant, compare to the antipsychotic? So citalopram is an antidepressant. It's a serotonin reuptake inhibitor. Your brain releases a chemical called serotonin, and when serotonin is released by the nerve, then the neurons suck it back up, and the action of the serotonin is terminated. What citalopram does is it prevents that serotonin from being metabolized or sucked back up from the neuron. So more serotonin stays in the brain. Risperidone is an antipsychotic. What antipsychotics do is they block dopamine. There's another chemical in your brain called dopamine, and what antipsychotics do is they block it. They block dopamine. So in this study, they're going to compare citalopram versus risperidone. So how well does the antidepressant citalopram compare with the antipsychotic risperidone? So again, 104 elders, randomize them to each. They're going to try and have it go for 12 weeks. Try 12 weeks. And again, you can see the mean ages here. This is another inpatient study. Mean age is about 80. Again, the mini-mental is terrible, right? That's severely demented. You can see, about 40% or so are psychotic. The dropout rate, again, is huge. It is nearly impossible to do these studies without huge dropout rates. It's just impossible. When you look at, so this is the observed agitation score. So in your mind, so the circles are the time. So here we have time, right? Weeks going along the bottom. We have the agitation score on the y-axis. So what you can see is over time, agitation is decreasing. Over time, agitation is decreasing. If you're in the circles, so you got citalopram, right? You have citalopram. So the citalopram group is going down. If you're randomized to risperidone, you're represented by that triangle. The risperidone group, the agitation is going down. So in your mind, you tell me, is there any difference, when you look at these graphs, is there any difference between the antidepressant and the antipsychotic? Or do those basically look the same to you? Right? They basically look the same to me, right? There doesn't seem to be any real difference. Maybe at 10 weeks here there was a difference, but that difference didn't last, right? So what you can see is that there doesn't really seem to be much of a difference between citalopram, the antidepressant, and risperidone, the antipsychotic. And even when you look at psychosis, you would think, well, my gosh, the antipsychotic should do better for psychosis. But even it, there's not a whole lot of difference until you get maybe 3 months in, right? Of course, the dropout rate, these are the ends, so you're going from 51 subjects at the beginning, finally at the end you end up with like 27 people, right? So the curves are just dropping, 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 people are dropping out, and the data down here, there's so much dropout, it's probably uninterpretable, to be honest. So in this study, the antidepressants seem to be as effective as the antipsychotic. People will ask, well, okay, well, if antidepressants, only one of them has been shown to be effective, what about mood stabilizers? So mood stabilizers is the class of medication that is used to treat bipolar disorder, right? So this is like Depakote, and Tegretol, and lithium. These are mood stabilizers. They're used to treat sort of the mania of bipolar disorder. And in your mind, you can kind of think that really bad agitation and aggression can kind of look like mania, right? It can sort of look like it, so maybe mood stabilizers will help. So there have been 5 studies with mood stabilizers, and only one time was a mood stabilizer found to be helpful for agitation in elders. And the one that was found to be helpful was carbamazepine. Carbamazepine, also known as Tegretol. Okay, so Tegretol or carbamazepine. That's the only time it was found to be effective. I can tell you anecdotally, what carbamazepine seems to be helpful for is when patients find themselves in a repetitive behavioral loop. It can break the loop. So for example, you know, if you've ever been in a nursing home or a hospital, there might be a patient in a room, and that patient will be in there and they'll be doing this. They'll be saying, help me, help me, help me, help me, help me, help me, help me. And it can go on for hours, right? It can. You've heard it. You've been there. Help me, help me, help, 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 help. And it's just this repetitive loop, and it just goes on for hours. And the nurse will go in, and she'll say, or he'll say, what can I help you with? And he'll look up, and he'll say, yeah, I don't know. And then the nurse will leave, and then the patient will go back into that loop of help me, help me, help me, help me, help me. And it just goes on forever and ever and ever. Kind of a physical exam of when patients, or physical finding when patients will go into these behavior loops are the tray bangers. So when they're sitting at the lunch or dinner or whatever, and they're the ones that just bang, 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 bang on their tray. And it's like they just can't help it. It's just, they just get caught in this loop. So carbamazepine works on the thalamus. It's a deeper structure in the brain. And for whatever reason, carbamazepine is the medicine that seems to break that cycle. It can break these repetitive loops. But there's only been one very small study, and so that was carbamazepine. People will say, well, what about the acetylcholinesterase inhibitors? So acetylcholinesterase inhibitors are FDA approved for dementia, right? They're FDA approved to slow the cognitive decline. They're not for behavioral disturbances. That's not how they got their FDA approval. They got their FDA approval by demonstrating a reduced rate of cognitive decline. But nonetheless, maybe they help. And so, so there have been 6 randomized controlled studies with mood stabilizers. 3 have reported modest, statistically significant benefits, but the clinical significance is always questionable. The challenge with the acetylcholinesterase inhibitor studies is that all of these studies have patients, they all have high numbers of subjects in the study. So if you have a medication, if you're a drug company and you have a medication that you're trying to see if it helps or not, but say your medication has a small effect, it might help a little bit, but not a lot. The way that you increase the odds of finding a statistical difference is to recruit a lot of people into the study. you overpower your study. You put a lot of subjects into the study, and that allows you, when you do the statistics, to see if there's a statistical separation. But there's a difference between a statistical separation versus a clinical separation. So when you do the math, the two groups might separate in the math way, but there's no real difference in real life, right? And so, so for example, you know, if you were looking at an acetylcholinesterase inhibitor for cognitive decline, if at the end of your study the treatment group, their mean MSE score was 22, and the placebo group, their mean MSE score was 21, is that a real clinical difference? Probably not. Most clinicians would say no. So in your own mind, you have to decide, you know, although the math might say it's helpful, in real life, is it helpful? So these studies have modest statistical benefits, but maybe not in real life. Where acetylcholinesterase inhibitors do seem to help with dementia-related agitation, there's one type of dementia that they really do seem to help. There's one type. What type do you think that is? They really seem to help. Anybody know? Lewy body dementia, right? Lewy body dementia is the dementia type that acetylcholinesterase inhibitors seem to help. So do you remember what Lewy body has? Visual hallucinations. That's right. It was that one that had visual hallucinations, Parkinsonism, and the fluctuations of attention, right? So acetylcholinesterase inhibitors really do seem to help for Lewy body, just not as well for the other dementia types. Okay, so that brings us to antipsychotics. And so without a doubt, I get the most questions related to agitation and dementia have to do with the antipsychotics. And this has to do with the black box warning, right? So the FDA black box, quote unquote, black boxed the use of antipsychotics in elders with dementia, right? So what this means in real life, if you're ever watching a TV ad or you're looking at an ad in a magazine, there might be a medication that's being advertised. Maybe it's Abilify, for example, just to say Abilify. There might be an ad for Abilify. They're advertising Abilify for help with bipolar disorder. But what you'll always see in these ads is there's always going to be a warning that goes across the bottom of the ad that says, this medication is not FDA approved for use in elders with dementia. That's a black boxed FDA warning, and it has to do with the potential dangerousness of these medications in elders. And we'll talk about what those are. So, atypical antipsychotics, there are, these are the ones that have been studied to date. So risperidone is Risperdal, Olanzapine is Zyprexa, Aripiprazole is Abilify, and quetiapine is Seroquel. Those are the brand names that you might be familiar with. So right away, the thing I want you to appreciate right off the bat is that there have been 11 randomized controlled trials with atypical antipsychotics, and actually there's now with the Katie, that makes 12. There have been about a dozen, just say about a dozen with antipsychotics. So although antipsychotics are black boxed for use in elders with dementia, the truth is that there's more data that there have been more studies that have looked at them. So if you're practicing evidence-based medicine, there's much more evidence supporting antipsychotics than anything else, than the other medication classes. Why is that? Why have drug companies looked at antipsychotics more than they've looked at any of the other medications? You know why? Why do businesses do anything? Money, right. So all of these studies were done when the antipsychotics were patented, right? They were patented, right? And so there were no generics, right? Whereas all the antidepressants, all of those had already gone generic. So you can't make money on a medication that's gone generic, right? You can't make money on a generic medication. But you can make money if you can get a new FDA indication for a medication that's under a patent, right? So at the time these studies were done, a one month supply of 20 milligrams of Olanzapine might cost $500, right? So Olanzapine's FDA approved for schizophrenia, but you tell me, what are there more of? Are there more people with schizophrenia, Or are there more elders with dementia? It's not even close, right? So if you're a drug company and you can get an additional FDA indication for a group of patients that there's so much more of, then all of a sudden you can become very profitable, right? So there have been more studies done on antipsychotics, and every one of them has shown some benefit. So again, antipsychotics, all of these antipsychotics here, they all work by doing the same thing. They block dopamine and they block serotonin. These are dopamine, serotonin antagonists. And so if you look at risperidone, of all of the antipsychotics that have been studied, the one that's been studied the most is risperidone. And so this is just data from 3 studies. It's pooled data. These are all 12-week-long, multi-center, randomized, double-blind, placebo-controlled. You can see that the average age is about 80. The mini-mentals continue to be terrible, right? It's like 7. Severely demented population. Most of them have Alzheimer's disease. The dropout rate here is now about 30%. About 30% are dropping out in the risperidone group. And then if you follow the red line, this is a mean change in baseline. So as the graphs go down, the agitation goes down. So the red is the placebo, the blue is if you're on medication, and what you can see at the end of the study is that the medication-treated group, the risperidone-treated group, is less agitated than the placebo group. Right? The antipsychotic-treated group is less agitated than the placebo group. And so, in this pooled analysis, the risperidone seems to help. It seems to help. Here we're looking at the risks, though, right? And so these are the side effects from being on risperidone. So about 20% of the sample is having a fall, whether they're on placebo or risperidone. Those are about equal. We know that risperidone is more sedating than placebo, so it's about twice as sedating as placebo. Extrapyramidal side effects, those are kind of the muscle tightening side effects that we'll see, and those, in this study, a little bit more for risperidone. But then we have stroke. And what you see here is that although the numbers are small, 1.6% of the placebo group had a stroke, 3.9% of the risperidone group had a stroke. Even though the numbers are small, it's still double, right? It's still double. And so I want you to kind of hold those numbers in your mind, the 1.6 and the 3.9. So the risperidone group seems more vulnerable to strokes than the placebo group. Okay. So they've also looked at olanzapine. So olanzapine, again, is Zyprexa. Here we have 206. All of the studies I'm about to show you, these are all done in nursing home residents, not outpatient. There's only been one in outpatient. That's the Katie study, and we'll talk about it too. Randomized to olanzapine or placebo for 6 weeks. They're using the NPI, that instrument I showed you at the very beginning, to decide if this medication is helpful. Again, the age, about 80. They're looking at 5 milligrams, 10 milligrams, 15 milligram doses of olanzapine. The mini-mentals continue to be very poor. The dropout rate is 24% for placebo, and then it seems to be a little dose-dependent for olanzapine. Up to about a third of the sample drops out who's on the highest dose that was tested. We can look at the change in aggression, and what you'll see is that compared to placebo, placebo dropped about 2 points on the scale, and the olanzapine-treated group dropped about twice that, about 4 points on the scale, right? So the way to interpret this is that at 5 milligrams, the olanzapine-treated group seemed to work about twice as well as the placebo group. But as you go up on the dose, you don't necessarily get better results. In fact, maybe even get worse results, right? So going up and up and up and up and up on the medication may not be the way to go. Again, side effects. It's all about side effects. So what you clearly see here is that as you go up and up and up on the dose, the risk of falls increases, the risk of sedation increases, and then the risk of gait abnormalities seems to stay about the same, but is much higher than placebo. So this is abnormal gait and a hard time walking. 2% in the placebo group, about 15% or so in the treatment group. So the side effects are not insignificant. This is an Abilify study with Aripiprazole and Agitation. So about 487, again, nursing homes. These are all done in nursing home patients. The numbers are always huge. They're randomizing to these different doses, using the MPI as their agitation scale. And again, when you look at the change in agitation, the placebo group drops about 1.3 points. The treatment groups drop about 2 points. That's pretty subtle, right? Like that's an example of something that might be statistically significant, but is it like real life significant? You know, maybe not. Maybe not, right? And then you can look at the side effects, comparing placebo with the other doses of aripiprazole. And what you'll see is that the risk of falls is higher in the Abilify treated group, especially at the lower doses. Not too much difference in somnolence or gait. But here what you'll see is strokes. So if you're in the placebo group, nobody in the placebo group has a stroke. But if you're in the treatment groups, your risk of stroke goes up. The numbers are small, but they're there, right? So that's like 2 studies now that have shown increased risk of stroke with antipsychotics. So the challenge with these studies is that they are all inpatient. They're all nursing home studies. They have huge dropout rates. And then the time that they're able to follow the patients is somewhat limited. So then what happened is that the NIH, National Institute of Health, the government, decided that they wanted to finally really answer this question. So they developed the CATIE study. And so the CATIE study was to measure the effects of antipsychotics on behavioral problems in Alzheimer's disease as it pertains to agitated behavior. And so what they did was they took 421 people, right? And what they were going to do is randomly assign them to either Zyprexa, Seroquel, or Risperdal, one of the 3. And they're going to do 6 follow-up appointments, and they're going to go 36 weeks. So this is like the government saying, these drug companies don't know what they're doing, or they just don't have the resources, and we're going to really figure this problem out. Right? This is the NIH saying, we're going to really try and figure this out. We're going to do it for 36 weeks with more follow-up, and we're going to do it outpatient, not just kind of bedridden nursing home patients. And then they thought, we're also going to use a ton of screens. We're going to look at behavior from multiple ways. We're going to screen them for depression. We're going to see if they help with cognition. Maybe antipsychotics help with improving functional status. Maybe they reduce caregiver burden. We're going to check out their quality of life. Maybe the antipsychotics are helpful for improving quality of life. So not just agitation, but all these other psychiatric scales. And so the mean age of their sample was about 78 years old. A little over half are women. And again, the problem, the federal government didn't do any better than the drug companies. 80% discontinued the medication before the end of 36 weeks. 80% dropout rate, right? The dropout rates in these studies are enormous. The dropout rates are always enormous. Therefore, they had to limit their analysis to only 12 weeks. They wanted to do it at 36, but they just didn't have enough power. Yeah, so the question is why is the dropout rate so high? And the question is, maybe it's because of side effects. So it is. It's because of side effects, and it's because caregivers don't perceive that the medication is working, and because the agitation is so severe, they don't want them just to be on a placebo, so they want to break the blind and put them on something that they know might be helping. Or put them on something that they think could help, instead of risk just leaving them on placebo. That's why. Yeah, but they're still fighting. They're still fighting, right? They're fighting. So then, this is a whole lot of data here that illustrates this, which is that at the end of the study, the risperidone, olanzapine, and quetiapine groups helped, but they didn't help much. Like this graph looks really impressive because this dot here, the placebo group, looks like it's very far away from the olanzapine, risperidone, and quetiapine group. But like when you do the math, you can see that it's only about 0.6 points away. So if you have to use decimals to mark off your graph, you're not doing very well. Okay, so here these aren't even whole numbers; they're decimals. And so the medications seem to help. They can statistically separate, but in real life they don't really separate. And most people consider the Katie study to be a negative study, that it demonstrated no benefit of antipsychotics for agitation compared to the placebo. So, not only was there no difference for agitation, but the antipsychotic group didn't have any benefit for any of these other things either. They didn't have any benefit for functional status, or cognition as measured by the ADAS-Cog or the Mini-Mental. They didn't improve quality of life, and they didn't improve caregiver burden. Okay? So this is like a completely enormous negative study. But this started to yield a lot of a lot of data, particularly with regard to side effects. And so what was noticed is that the patients who are treated with antipsychotics seem to die a little sooner than the people on placebo, right? They died a little sooner than the people on placebo. And so what was seen was that if you were on placebo, the chances of you dying during the 12-week study were about 2%. If you were on an antipsychotic, the chances of you dying during the 12-week study were about 4%. So if you do the math, if you take the inverse of the difference between the two, you get 50. You calculate the number needed to harm, which is 50. So what this means is that for every 50 elders who are treated with an antipsychotic for dementia-related agitation, one will die, and it's because of the drug, right? One will die, and it's because of the drug. So for every 50 elders that are treated with an antipsychotic for agitation, one will die because of the drug. So now, it becomes existential, right? So now it becomes, what is your relationship with death, right? And if you have a good relationship with death, right now you're thinking, well, 1 in 50, that's not so bad, right? But if you have a bad relationship with death, you're thinking, my God, 1 in 50, that's a lot, right? I mean, how many elders with dementia does how many elders with dementia might a psychiatrist or a private practice family medicine doctor see in a month? Probably about 50, right? Probably about 50. So, so that's what led to the black box warning. And the same was true with stroke. The same statistics were true for stroke, where about for every 50 elders with dementia treated with an antipsychotic, one will have a stroke, and it's because of the drug, right? And that's why these medications got black boxed by the FDA. That's why they have this specific warning, and if prescribers prescribe them, they're essentially going against this FDA warning, which makes them very vulnerable, in fact, to litigation, is what it does. Okay? So when we use these medications, we have to be, the conversation that I have with families is that I tell them what we know. What we know is that for every 50 elders that are treated with these medications, one will die. It's because of the drug. So then the question is your loved one's, is the agitation, is the aggression, is their quality of life so impaired that we're willing to tolerate a 1 in 50 chance of killing the person we're trying to help, right? And sometimes the answer to that question is no. No, we're not there yet. I'll just keep doing the best I can. I'll do what I can do. But then sometimes the answer is yes. Sometimes the agitation is just so severe it's so disorganized, the elder's quality of life is so bad that the family members are willing to take this chance, are willing to take a risk. Yeah.
How do you explain the reduction of agitation on those studies for the placebo group? Because it was kind of mapping it.
Yeah. So the question is how do you explain the reduction in agitation for placebo, for the placebo group? And so, yeah, you know, time cures a lot of things, right? You know, time cures a lot of things. And I think the other truth with the placebo group, you know, the placebo isn't just the placebo, right? It's not just the placebo pill. The placebo group is getting extra attention. They're going to all these doctor's appointments to have their agitation measured. They have much more eyes on than they would if they were not in the study at all. And so it almost makes you wonder if just sort of the benefit of being in the study, the extra attention perhaps, is helping the agitation go away. Does that make sense? Yeah. The other truth is that the placebo rate in psychiatry is always high. It's always about 30%. No matter what medication you're looking at, the placebo rate is always about 30% in psychiatry. Whether you're doing a depression study or a bipolar study or a schizophrenia study, the placebo rates are always high in psychiatry, always about 30%. So this is a few years ago, this was in 2011. I just wanted to look at what I was doing in my clinic. And so I thought, I wonder, you know, what, it's always good to kind of look at what you're doing and, you know, see what you can make of it. So this was my Geriatric Psych clinic in 2011. I saw, I guess, 168 elders. I only have clinic a day, because of my other academic things that I do, I only have clinic a day a week, so I only had about 168 that were seen that year. And then the dementia diagnosis, about 73 had dementia. To make a long story short, about a quarter of my dementia cases were on an antipsychotic. About 27% of my dementia cases were on an antipsychotic. About 1 in 4 is what I was doing. The other medication class that you didn't see, that there hasn't been any studies on, is benzodiazepines. So what are examples of benzodiazepines? Yeah, Valium, Xanax, Ativan, Klonopin, right? Clonazepam, lorazepam, temazepam. There have been no studies. There have been no studies with those medications, those sedative medications. How come? There have been no studies on this. Because they're generic. Yeah, you can't make money off of generic. Yeah, exactly right. Because they're generic. That's exactly right. Yeah, so they're generic. No one's going to make any money, and so so no one's studying them. Right? However, that being said, whenever you do these studies and you're trying to get institutional approval, you're going through the IRB. Even and this might also answer your question about placebo, is that regulatory bodies don't like the idea of a patient only being able to receive a placebo. It just seems cruel, right? Like you're withholding treatment, if you will. So in every study, they'll say, well, for breakthrough agitation, you can give them 0.5 milligram of Ativan for breakthrough. And that PRN dose might explain also they're not just getting placebo, right? And so that also kind of makes things sticky. All right. So this is what we know and what we don't know. I think it's also important just to kind of frame the to clinically frame the dilemma. You know, the dilemma is this. The dilemma is that a patient, that a family member is bringing me a patient. They're telling me that you know, their mom lives at home with them. She's had dementia. They've had to move her into the home. But every time they try and bathe her or anything like that, she strikes out and she fights. She's biting her care providers. She's up all night, walking around at night. She won't go to sleep at night, so she's walking around all night. And what the family will say is something like, if something isn't done soon, I'm going to have to put my mom in a nursing home. I need something to happen this week, otherwise I'm going to have to place my parent. Or that maybe they're already in a nursing home, and then the family's coming to me saying, if you can't fix this problem in a week, the nursing home is telling me that she just can't stay there anymore. That's not the environment for her. I'm going to have to find her a new place. This will be the third place I'm having to place her, right? So, I think it's important to it's important to appreciate the desperateness, if you will, of the family members trying to get help. Okay, so this is what we know. What we know is that there's no FDA indication for any medication to treat agitation or psychosis in patients with dementia. We know that. We know that off-label practice is common, right? In that big Cache County study in northern Utah, right, like 1/4 of the patients are on psychotropic medications. In my own clinic, it's about 1/4 of the patients are on antipsychotics. So there's no FDA-approved medication for these behavior problems, but what we know is that physicians do this all the time, right? About 1/4 of them are on some sort of medication for this. We know that there have been more randomized controlled studies for antipsychotics than for other classes of medication. We also know that there's more data for risperidone than there is for any other antipsychotic. That's just true. You can just look it up, and that's just true. We know that the studies show a modest efficacy for antipsychotics, but we also know that the placebo rate is high. Going back to your point, the placebo rate is always about 30–40%. We know that the incidence of mortality and stroke is higher, right? For every 50 patients that are treated with an antipsychotic, 1 will die, and it's because of the drug. We know that atypicals in general have fewer side effects, but there's been no differences demonstrated in efficacy or safety. So this is like Haldol. So Haldol, atypicals are medicines like risperidone, quetiapine, olanzapine. And there's typical antipsychotics, the older ones like Haldol, right? So we know that the newer medications have less side effects than the older ones like Haldol, but we don't know that they're any better, right? Any more effective. Let's see here. Every medicine is going to have, there's always going to be individual medication differences. We know that. What we don't know, and so this is what's unknown, we don't know the risk of stroke and death beyond 8 to 12 weeks. That's it. All of these are 12-week studies. For all we know, antipsychotics make you live longer if you can be on one for more than 12 weeks. Maybe that's true. I doubt that that's true. But maybe it's true. We don't know, right? So we don't know the risk of death or stroke beyond 8 to 12 weeks. We don't know any risk factors or protective factors for stroke or death. We don't really know the efficacy and safety of alternative treatments, including our psychosocial interventions. We always start with psychosocial interventions first. We don't really know how effective those are, right? Not really. Is music therapy effective? I like to think so. I really do. I like to think so. But if you did music therapy versus Risperdal, what would win? Man, I don't know. I truly don't know. I would like to think music therapy. I really would. But I don't know. So then here are the recommendations. The recommendations, these come from the American College of Neuropsychopharmacology. So determine and treat the cause of agitation first. Again, we're always trying to look for reversible causes. Do they have a urinary tract infection? Treat the pain. If they're delirious, we'll always treat the delirium first. So try and figure out what is causing the agitation. So good routine clinical care might be as helpful as evidenced by the placebo response. This goes back to what we were discussing before. Maybe just seeing the patient regularly and routinely, seeing them every month, giving the family kind of the support that they need to hang in there. Maybe that is as helpful as anything. Clinicians need to make decisions based on the patient's and the family's values regarding quality of life goals. So again, this is me saying, is the situation so bad that we need to have an intervention now? Is their quality of life so impaired that we're willing to tolerate this risk? We identified the target symptoms and we established a time frame. at least a month. So the time frame needs to be at least a month to try and figure out if these medications are going to help or not. We also just remember that just because a patient's psychotic doesn't mean you have to treat them, right? So this kind of goes back to the Lewy body dementia case that I was talking about before, where the patient sees little men walking across the mantle. Like, it's okay to not treat that, right? You can just let that go, right? We're going to pick our battles, and maybe there's some things we just let go, right? We always use the lowest dose of medication for the shortest period of time necessary. We're monitoring regularly for side effects, monitoring for blood pressure changes, body weight changes. The average weight gain on Olanzapine, on Zyprexa, is 30 pounds. That's the average weight gain, 30 pounds. And that's not water weight. That's like, it changes your metabolism, right? 30 pounds is the average weight gain on Olanzapine. And the others aren't much better. Let's see here. We always educate patients and caregivers about the risks and benefits. If something's not working, then we will stop it, right? So I always tell people that, you know, any idiot can write for a medication. I do it every day, right? So any idiot can put a patient on a medication. That's not hard to do. What is hard to do is to stop medications. And that's what I always tell my residents. I always tell my residents, you know, what makes a physician is knowing when to stop medications, not knowing when to start them, because that's easy. Okay? Coordinate the care with other professionals to minimize the risks of treatments. That's us continuously talking with the nursing staff, etc. And that's what we do. So, so probably just again, anecdotally, probably the things that I see most common, part of the mistake I'll see most common is it has to do with quetiapine. And so again, I don't have any financial disclosures. I don't get any kickbacks from any drug companies at all. But what I know is that quetiapine, which is Seroquel, blocks dopamine the least tightly. Because of that, it has the fewest side effects. This is Seroquel. And so at least what happened in San Antonio is that Seroquel kind of got the reputation as being the kinder, gentler antipsychotic, which is true. It does have less extrapyramidal side effects. But I also think that a lot of times for agitation, if you're using antipsychotics to treat agitation, really bad agitation, you want to block dopamine. And you want to block it tight and strong. And that is medications like haloperidol or risperidone, right? So the general algorithm that I'll follow is that if a patient comes to me, once we've exhausted the non-pharmacological interventions, I always start with an antidepressant first. Either sertraline or citalopram or something. I always start with an antidepressant first because I know that it could help and it's the least likely to cause serious side effects. If that antidepressant doesn't work, then I tend to add a benzodiazepine, which would be a sedative medication like lorazepam or Ativan or Klonopin or clonazepam. I add a sedative medication, and if that doesn't work, then I start to think about antipsychotic therapy. And if the antipsychotic therapy isn't working, then I don't just leave them on it. We stop it and we try something else. That's what. All right. Let's see. So yeah, we'll open up for questions. Yeah. Oh, so the question is are my patients on antipsychotics still alive? It beats me. Yeah, I have no idea. So, yeah, you know what I can tell you is that I've never started an antipsychotic on a patient who didn't survive 12 weeks after I started. I know that for a fact. I know that for a fact. But then beyond that, I'm not able to comment beyond that. Oh, so then the question is, are they still on it 4 years later? Most often not. Usually, so with agitation, with dementia-related agitation, so dementia-related agitation is caused by the brain degenerating. So the brain's at some given level of function, and it's degenerating, and then agitation emerges. But the brain continues to change. It continues to evolve. And so there's lots of times that, you know, maybe they'll be on antipsychotics for 6 to 12 months. And then after that, we'll try and stop them. We'll go down and we'll try and stop them. And probably at least half the time, I'm able to stop them altogether. And almost always able to go down on the dose. So, so no, they're not, it's pretty rare that I have an elder on an antipsychotic for years, if you will. Yeah, it's a good question. Yes, sir.
When we talk about interventions, you mentioned the medical part of it, but also I'd like to know if there's any studies talking about any type of psychotherapy that can work with patients with dementia.
Yeah, so the question is, right, is there psychotherapies that work with patients with dementia? So are there studies? Yes, there are studies. But I think those studies, they're always small numbers, like incredibly small numbers. Psychotherapy studies are so expensive. They're so expensive and they're so sort of unwieldy, because when you do them, you know, all of the therapists have to be doing like the same type of therapy in a controlled way. Psychotherapy studies are really expensive. So maybe that's why there's not as many of them. You know, I mean, I can tell you what does bother me personally is when I see that, you know, there are some patients who I see being billed for psychotherapy services who I just don't think can possibly benefit from psychotherapy services. They just can't communicate even. And so I do think for psychotherapy, the patient has to, there has to be some give and take communication between the therapist and the patient, right? There has to be some way that they can both communicate with each other. And I will sometimes see where patients who clearly cannot benefit from psychotherapy because of their severe cognitive decline, you can't even do the mini-mental on them anymore because they're so impaired. I don't know. That doesn't feel right. But I do think in the, you know, when we see a lot of the agitation happens before they get to that stage, right? It happens, you know, when their mini-mentals are in the, even the upper teens, in fact, where I do think they can communicate and where I do think that there is benefit there. Absolutely. Yeah. Good question. That's a good question. Let's see.
Okay, I think that's it.
All right.
We are going to have a break. Let's see, 5, 10, 15, 20. We'll start again at 2:25. I know that we're a little bit early, so we're going to head and end early. How about that? Sound good to me? Okay. So we'll start again about 2:25. We got snacks, we got burgers. Take some sandwiches. If you don't take them, we're going to throw them out. We don't want to do that. Our next talk is going to be about alcohol use and dementia. And I heard that the hostess is going to bring out a margarita machine. So no limit, 1 per, and if you're under 21, to that.
Won't you come see about me? I'll be alone. Dancing, you know it, baby. Tell me, your heart's me out. Giving me everything inside me. A love string, so real in the dark. Until the things that we were working on. Slowly, pull us apart. When the light gets into your heart, baby, don't you forget about me. Don't you forget about me. Will you stand for me? Look my way, but never love me. Rain keeps falling, rain keeps falling. does not have me. They call my name or walk on by me. The rain keeps falling, rain keeps falling. Won't you try and pretend it's my feeling? We'll get in the end. I won't harm you or touch your defenses and vanity and security. Well, don't you forget about me. I'll be alone dancing, you know it, baby.